afternoon, everybody.
Good afternoon.
Hi, my name is Dr. Naushira Pandya. Really happy to be here. This is Oksana Schneider. We're both from Nova Southeastern University, and I'm chair of the geriatrics department, and also head of the geriatrics workforce enhancement program. So that's a big federal grant, and this nursing home curriculum, training in nursing home care is part of it, okay? And so our focus is on age-friendly healthcare. And I don't know if you're familiar with this, but I'll just say a few words about age-friendly healthcare. And if you remember the 4 M's, then you're like pretty good at taking care of your patients, if you remember the 4 M's, okay? So one of the first M's is what matters. What matters to your patient? You know, the personal care, the food. They don't want to go to the intensive care unit. Those are the kind of things that we need to know about our patients. What matters to them? Then medications, right? I'm sure you've seen a lot of people on medications, maybe some side effects of medication. So that's another M that's important, okay, in every older adult. The third M is mentation. So treating dementia, depression, or delirium. You guys have had some training on delirium. Today I'm going to talk about dementias, the behavioral symptoms of dementia, okay, which I'm sure you see a lot in your patients. Okay. So, and the last thing is mobility. So that's the 4 M's, okay, matters most, medication, mentation, and mobility, okay? And that's how we, even as physicians, as clinicians, that's how we try to address, the care of our patients. And I thought further, okay, what really matters to patients? Food matters, right? The people around them matter. They have to feel secure and safe. Money matters, right? If they don't have financial support, sleep matters. But I think what John Knox is really good at is personhood. You treat people, like they're unique. You treat them with dignity and respect.
Yes.
So that really matters to patients, okay? And so this is the 1 M, what matters most. I told you about mentation. The 3 big areas we look at with the brain is dementia. How many of your patients have dementia? Majority or 50%? 50 plus, maybe less in the rehab unit? Okay, so it's so common, right? And I've treated dementia patients all my life. Depression, they're prone to depression like anybody else, but more so as you age. And then delirium is confusion, usually from a medical problem, and infection. Low blood sugar can cause confusion, right? And acute confusion. So that's those are the 3 things in mentation. Medication is important because as clinicians, we have to see, is it necessary? Are they on too many medicines? Did they get mixed up? The hospital sent the same medicine with a different name that they have at home. They're going to mix them up together, okay? So keeping the medication straight. Are they too costly? Can we do a generic medication? Is insulin going to be more affordable? Yes, for Medicare patients, all right? So medications really matter. And that, again, affects everything. It affects mobility. Medications affect your mentation. So you see how 1 M can affect everything else, right? So medications can affect a lot. And then mobility. How many of your patients have fallen and you had to pick them off the floor, and skin tears, bruises, right? You have to write a report and talk to the family. So the mobility is really important in whatever setting. We want to try to keep patients safe. And so we look at fall hazards, make sure they have the right rolling walker or cane or the wheelchair if that's what they need. When they go home, we have to think of modification of the home. And again, medications can affect mobility, right? If they get unsteady, if they get drowsy, if they get a tremor, it's all over, right? As far as the risk of falling. So you see, all the M's affect each other, right? So anybody want to quickly tell me the 4 M's?
Education,
mobility, and matters most, right? And I love this board because tells you what matters most, right? From hopelessness to joy, all the things that you address in helping people become more self-sufficient and independent. So here's a case. I want you to think about this patient, and I'm sure you've seen them 100 times. Same patient, right? 75-year-old man in a long-term care ward. He's losing his appetite, he's withdrawing, he's not talking to anybody, no activities, getting very withdrawn. He struck the CNA or the Shabazine several times while they were trying to get him to have a shower. He won't let anybody touch his left arm. Just fighting them. Don't do it, don't do it. He's fighting. Okay. Vital signs are okay. And the reason, anytime there's a change in mental status or change in condition, you want to check the oxygen level, okay? Because it could be they're low in oxygen, that can kill you. And a low blood sugar can kill you, okay? There's a low oxygen, low blood sugar, in addition to your blood pressure and heart rate, you want to check that. Are you folks allowed to do an oxygen saturation? Can you do that on the?
Mm-hmm.
So they can, so perfect. So you have to, anytime there's a change in a patient, do an oxygen saturation. And you or the nurse will probably do a blood sugar. Even if they're not diabetic, do a blood sugar, okay? So that's important. So what do you think is going on with this patient? Why is he not eating, withdrawing, he's really fighting in the shower, won't let anybody touch his arm? What could be going on?
Maybe in
Could be.
pain.
Depressed, okay, that could be,
Urinary tract.
could be.
He might
So-
be in pain.
He won't let anybody touch his left arm.
Oh, okay. So
Okay, what do you think?
he should have.
So all the suggestions are good, urinary
could have
tract
fallen,
depression.
right?
Yes, and,
And probably bruises along or maybe
yeah,
dislocated. Or
could
something.
even be a hairline fracture or
Yeah.
something, right?
And
And
nobody-
it's hard to know,
Yeah.
and people might not have seen the fall, there's no
That's true.
incident report. But when somebody's protecting something, you really have to get your nurse, the doctors nearby to do an evaluation, okay? And the vital signs, the oxygen level and the blood sugar. Okay, low blood glucose and low oxygen can kill you, it's as simple as that, if you don't pick it up. And you know during COVID how people suffered with low oxygen, right? So I know we've all had stories with family members or people we know who've suffered through COVID. So this is, so you're right in looking at this. And I just want to say dementia is very common. The yellow part is people over 85. So we're about here right now, but as time goes on, in the next 30 years, probably 50% of people will have dementia. Okay, so that's a huge number, right? So dementia is common, and you all see it anyway. Loss of brain cells, atrophy of brain cells, there's actual shrinkage of the brain. You have less brain material, which is really scary when you think about it. But when you look at MRIs, CAT scans, there's less brain. Okay. So just to give you a little background, signs of dementia, I'm not going to go over that because I want to talk more about the behavioral symptoms. So with dementia patients, what is your goal? What are you trying to do here? Let's say a long stay ward. What's your goal with the patients? What are you hoping to do?
Make the patients feel comfortable.
Sorry?
Make them feel comfortable.
Comfortable, right? Good quality of life. And again, the 4 M's matter, right? We listen to what matters to them. We get them on the right medications. We keep them as active and mobile as possible. And mentation, right? If they have depression, we try and treat that. If they're delirious, we treat that, okay? So treatment targets, again, for dementia patients are, we want to preserve as much brain function as they have. We don't want anything or any medication to make it worse, all right? Improve their mood and behavior, to slow the deterioration of their condition. And dementia patients are just as likely to develop anxiety and depression like anybody else, okay? So again, we have to, on top of that, if you're a patient who's normally cheerful, going to activities, stops talking, stops interacting, yes, you have to think of depression. Or something's going on that's harming the patient, okay? So this title of the lecture was Behavioral and Psychological Symptoms of Dementia, right? And I'm sure you've seen a lot of this. On the left is the psychotic symptoms. Have you seen somebody who's hallucinating or doesn't recognize you, or they say you're trying to poison me, or you stole my wallet? Right. So those are delusions, right? That's abnormal thinking, bizarre behavior, agitation. We've all seen it. Has anybody been hit by a patient?
All the time.
All the time. Me too. Spit by a patient? Yes. All of the above, okay? All the time. And it's not intentional, but dementia is part of the problem. So those are the psychotic symptoms. They don't recognize people. They're a bit paranoid. Then mood symptoms. We talked about depression. They might just get tearful. They might feel hopeless. They might feel very lonely and isolated. So that's the mood part. And then the behavioral part is what we often struggle with, right, in the day-to-day care. They're taking their clothes off, right, wandering, repeating, saying the same thing over and over again drives you mad, right? So those are the behavioral symptoms, sexual behaviors, okay? Turning day and night around. Have you seen any other behaviors that you can think of in your patients that I might have missed?
Usually they think about stuff that happened in the past.
Yes,
They probably asking you for their parents.
yes,
Their
and that's
mom,
part
their
of the
dad.
dementia. So they're remembering the past, right? Or they have to pick up their daughter from school,
Yeah.
right? Or some things they have to, they forgot something, they have to go home and make dinner,
Mhm.
right? So what do you do with that patient? What's your approach? What's your approach? Because that's what we
Wherever
want to
they are,
discuss.
you try to be there with them because
That's it, right? So you discuss where they
Yeah,
are,
where they
right?
are.
That is the key, is to be where they are, right? Not to correct them. No, you're here, you're in Woodlands, this is whatever year it is, 2023. Okay, don't correct them, you're with them, okay. So this is the whole,
Dr. Pandya, if I can stop this.
yes,
When you said don't correct them, is there a rationale for that? I
Yeah.
know what it is, but I want to hear you say why we shouldn't correct them in certain circumstances.
so, so what do you guys say, why should we correct them? Everything they say, if it's wrong, why should we not correct them?
Because they already, you're not there to correct them. You're there to help them feel comfortable. Like if you're telling you're gonna make them more
Angry,
Yeah, it distresses them, and
Yeah.
what is gained by that? Nothing.
Yeah.
They won't remember the correction. Oh, I know it's Tuesday, I have to do this. No, they're not going to remember. So to keep their quality of life as calm and
Yeah.
pleasant as possible. So 90% of people with dementia develop these behavioral symptoms. So it's common. We just have to live with it, okay? And the problem is if you're at home, the caregiver can get very frustrated, they're losing sleep. Sometimes they can even get abusive with the patient because they lost their patience, all right? So that's called caregiver stress. That can end up with the patient in a nursing home because the caregiver, the daughter, the niece, whoever cannot manage that anymore. They can't handle it and they often don't know what to do. So they can end up in the nursing home. They can often, if this persists and it's not managed, they lose weight, they fall, they could get an infection. While there are medical treatments for extreme behaviors, what I want to discuss is non-medical treatments, non-drug treatments. How do we manage these people? Okay, so let me go back a bit. What can lead to these behaviors in patients? Hitting, spitting, paranoia. What could lead to those behaviors? What do we have to, because as caregivers we have to think about what's leading to this and how can I make it better? How do I recognize it the next time it's going to happen? What are some of the triggers of these behaviors?
A different environment.
A change in environment, especially when they come from, let's say, the hospital or an ALF or something. Change of environment. What else? What can trigger these behaviors?
Approach, the way you approach them too.
Yes,
sometimes.
that's really important because if they feel threatened, too rushed, doesn't work. What else can trigger the behavior?
If they are UTI.
Yes, so always have to think, is there some medical problem? Because if a simple approach doesn't work, the new nurse has to know, she has to know anyway, she or he has to know. And then that has to be reported to the clinician. They need an investigation if things aren't working. What else can trigger these behaviors? I have some things. Pain, we saw that in the case I presented, right? Showers, right? That is very tricky. Oral care is very tricky, right? To do that and to, that might upset a patient. But think of it as a baby as well, okay? Hungry, thirsty, simple things. If you think of your child, you won't go wrong, okay? Hungry, thirsty, urinary retention, the bladder's full, large prostate, or they're on a medication, causes retention. What about fecal impaction? What can that do? Have you seen behavior problems? Yeah, I saw a patient who just kind of broke the room down. We looked at everything, then I did a rectal exam, and he was so impacted. And like 20 minutes later, when he was disimpacted, he was a different person. Okay? So fecal impaction, all the basics. So you almost have to think of like a baby, hungry, thirsty, needs changing. Okay? Urine problem, fecal problem. All the basics are really important. And again, I want you to remember one thing, low blood sugar can kill you. Okay, and it can cause definitely agitation, anxiety, and low oxygen level. And you all mentioned infection. So I think what I want to look at now is the approach. So some of you already talked about it. Non-medical, we're not giving medications right now. So on the left, the interaction, how you interact with the patient can make all the difference. And you said approach them slowly, right? Calmly. Don't keep a threatening distance, keep a nice distance. And sit down if it's eye-to-eye contact, right? Don't stand above them. Don't stand on the side or behind them, right? That's not going to help. And calm voice, no scolding or threatening, okay? Because if they're not going to go into the shower that day, they're not going to go into the shower, okay? No threatening or scolding is going to do it, okay? And so validate, be with them where they are, reassure them, and maybe even distract them. Talk about something they like to talk about. They like to talk about their daughter or their cat, or you have a pet on site. Distraction is important, okay, if they're distressed or acting out. Medical evaluation is very important. So the clinician, the nurse has to look, and are they in pain? Is there fecal impaction? Is there hearing problem? People whose ears are just full of wax, okay, dementia patients, they don't hear well, but they think everybody's talking about them, okay? So just earwax is important, all right? And are they depressed? They're not able to sleep. So look for those triggers. So this is the medical evaluation. And if you've looked at everything and nothing checks out, then they might need a medication, all right? Which could be an antipsychotic medication. And then our other approach is looking at quality of life. So in dementia patients, what really makes a difference is daily physical activity. Even if it's a walk, weed your flower bed, fold the laundry. Activity is very important, and a routine. Same routine with meals, nice experience with meals, comfort food. Do you care if a patient with diabetes has a piece of cake at that stage?
Yeah.
Do you care? You do care?
Trick
question. Does it matter if let's say you have a 90-year-old with dementia, they love cake.
Yeah.
You gonna give it to them?
You said they're diabetic, right? Did you say
Yeah,
diabetic?
if they're diabetic, they like cake.
Well, I would be kind of cautious in giving them the sugar. I would be. Me as a nurse, I would be.
Okay, but I wouldn't, and I'm an endocrinologist. Okay, so that's a trick question. So the thing is, at that stage, give them what they want to eat. Okay?
How often though that? How often?
But you see, that's the problem, how we were taught.
Yeah.
Yes, indeed,
follow
and I
it,
was too.
you see.
Then I learned in my specialty of geriatrics and endocrinology in older people. Even if you have diabetes, when you're that old,
What's the matter?
I heard that too.
The blood, having treats, maybe not every meal, right?
Right,
But a couple of times a week, the weekends, so you have an event for them.
Yeah. I remember we had a patient and then
Yeah.
she didn't want to eat nothing
Right.
on that cake. Cake. That's all she wants.
So we'll give them cake.
Well, I
The
feel bad for
family
her.
bring a cake.
And yes, the blood sugar might be high, but what you need, and that's another talk, is older people with diabetes are allowed to have slightly higher blood sugars. Okay, that's the recommendation from the American Diabetes Association, our own geriatrics associations. Okay, that's the they're allowed to have slightly higher blood sugars because quality of life and nutrition matter, right? Food matters to everybody. So give them cake. Okay.
If they want.
If they want. So I've told everybody to let me eat what I want. Okay. And Indian food. So don't restrict. Nutrition is very important. Yes, if their blood sugar goes high, they may need more medical treatment. They might need another pill or slightly more insulin. But certainly for celebrations, those events, we're not worried if every blood sugar is not perfect. We don't care. Okay? Obviously, they all should not be very high. We want to treat them. Okay? But the treats don't matter. So then other things with behavior in dementia patients, if you can have one-on-one, or if you can recruit a family member to help you, or if you have volunteers in your facility, that really helps. If that calms the patient, if they can sit with them, watch TV, reminisce, talk about their life, that really helps. Social support really helps. We want to avoid restraints, if we can. Definitely no physical restraints. How are you doing with restraints? Do you have any physical restraints?
No.
And most facilities don't, but sometimes for even a few hours, it may be necessary till the medication takes effect, or if they're really in the middle of a difficult procedure, or we don't want that IV to come out, So you may need to, but we want to use a medication to calm them down as much as possible. And of course, we generally use antipsychotic medications. We want to avoid medications in that Valium type category of drugs, okay, Ativan, Xanax, Valium. Because they, sometimes in older people, they have an adverse effect. They can agitate them more. I'm going to skip over that. So basically, it's time, attention. It's thinking of every patient with behavior is not the same as the next patient. What is the trigger for this patient? What sets them off? Okay, is it noise? Is it somebody trying to rush them and get them dressed, by the time it's time for breakfast? Are they being rushed? Are you missing something about pain? Have they got a full bladder and you missed it? Okay, so that's important. And then any signs of infection. How do you know somebody might have an infection? What symptoms? Because you're the first line people. How would you know somebody might be having an infection?
Sometimes they smell and they irritate too.
And
Smell,
behavioral
irritation.
symptoms.
Behavioral symptoms, what else? So you think of bladder, UTI, what else? What if they had pneumonia? How would you know? What did you say?
They're breathing.
They what?
I don't know about them.
Yeah, they could be congested. They could sound very congested. They've got a wet cough. You might even see some phlegm. Okay, so that's very important. They're breathing fast. Okay, because that's the kind of thing, if you pick up quickly, they get diagnosed quickly. All right, so I think I'll stop here. I really appreciate your attention. And then you've got your questionnaire to fill in, and the same thing here if you want to use your phone to complete.